Just 2 minutes. I'm just putting the session on the YouTube on live. Prasenjit sir, are you there? Am I audible?
Yeah, you're audible.
Yes, sir. Now, before we move on to the next session, I would request Dr. Mangala, Associate Professor of Department of Pathology, MGMCRI, to introduce the speaker to the forum. Ma'am.
Good morning, everybody. A warm welcome to Dr. Prasenjit, sir. Sorry for the delay in making you to present, sir. Brief introduction about our speaker. Sir is currently working as an additional professor of pathology at AIIMS, New Delhi. He is an alumnus of Calcutta National Medical College, Kolkata and PGI Chandigarh. He is also a visiting pathologist at the Beth Israel Deaconal Medical Center and Harvard Medical School, Boston. Sir has got special interest in the GI and the hepatobiliary pathology. He has got 180 publications in the international and national journals to his credit and more than 101 original research articles in his name. He is a member of several national and international organizations, like he is a member of IAPM, Indian Division of International Academy of Pathology, Renal Pathology Society, International Society of Study on Celiac Disease. He is also a member of National Science Academy India, Indian Society of Gastroenterology, member of NAMS, and he is also a member of US CAP and USA. Sir has got lot of awards and recognitions to his credit. To name a few, he has got the prestigious Professor N.C. Nayak Talented Young Pathologist Award, Delhi chapter in the year 2012. Young Investigator Award ISG India in the year 2015 and ISG Award Presidential Poster Award in the year 2015. Professor K.C. Basu Malik Award in the year 2011 of IAPM India for the Research Excellence Award from AIIMS, New Delhi. Professor Kalonkar Award and Professor Kunti Devi Malhotra Award for published papers of IAPM in the year 2018 and 19. Sir is also a member of the editorial board of the journal IJPM and he is also a reviewer to various national and international journals. Over to you, sir. Sorry for the delay and interruption in the course to you. A warm welcome to you. You can proceed.
Yeah,
sir.
thank you so much for that nice introduction. And I am really honored to be invited in this 1 week long conference at your center. And thanks to Professor Shomya and all the faculties, and especially to Dr. Venkat, because he reminded me I should not forget this event. And it is really an honor. So can I share my screen now?
Yes, sure, sir.
Yeah, just a minute.
Welcome, sir.
Thank you. Well, so Dr. Santosh was one of my seniors who taught me in PGI Chandigarh, and I am really pleased to present in the same forum where he was. So my topic of presentation or discussion is interpretation of small intestinal pathologies and malabsorption. So this will be my agenda. Just a minute, I will just hide the video panel. Okay, so these are my agenda. So I will talk briefly about the interpretation of small intestine, and we'll see what are the common small intestinal pathologies of malabsorption syndrome. Then I will talk about the adequate number of the biopsies, site of biopsy and orientation of small intestinal biopsies. Then we'll talk about some important diseases of malabsorption syndrome like celiac disease, tropical sprue and common variable immunodeficiency we see very commonly in our centers. Then we'll talk about histological mimickers. Uh, I will talk about some of the examples of malabsorption syndrome where histology plays a prime role in diagnosis. Then we'll summarize and we'll take up the questions. So before going further, uh, we all know what is malabsorption syndrome. Malabsorption syndrome is basically inability to absorb or transport the absorbed dietary substances. Okay, and the small intestine has been specially equipped for absorption of the luminal content, because we all know there are multiple mucosal folds. All these mucosal folds have multiple villi, and on the top of the villi there are multiple microvilli, numerous microvilli. These all has been created just to uh, uh, basically increase the surface area of absorption. And we all know the architecture of the mucosa slightly varies in the duodenum, in jejunum, and in the ileum. The duodenal villi are slightly stubby and short, and they usually are described as they are leaf-shaped. Okay, and the jejunal villi are really tall. If we talk about the villi which are in the proximal jejunum versus which are in the distal jejunum, the proximal jejunal villi are the tallest, like this fingers, and the distal jejunal villi are slightly shorter than that, but they are still longer than the jejunal villi. And the ileal villi are also slightly like shape of leaves, and their height is of intermediate size between the jejunal and duodenal villi. And we all know there are multiple absorptive surface, and in between there are punched out spaces which are actually goblet cells. These are crypts and these are the villi, and the number of the goblet cells and the number of the microvilli increases as we go down from the duodenum to jejunum as well as ileum. So in the ileum, the number of the microvilli and the goblet cells are the highest than the other part of the small intestine. Now, how we all know how the luminal absorption takes place. The luminal absorption takes place by the transcellular pathway as well as paracellular pathway. This is actually two enterocytes you can see here. This is the goblet cells, okay, and in between two enterocytes, this is the paracellular junction. And the most important character of the paracellular junction is it is guarded by various junctions, okay, junctional guards. The topmost is the tight junction, which is very potent, and if it is not working, then there will be malabsorption as well as there will be diarrhea. So this is a schematic diagram, or this is a cartoon just to show you what happens if there is inflammation or if there is some toxicities, whatever is going on. What happens? That destroys the tight junction, and as the tight junction is destroyed, luminal microorganisms and luminal antigens can enter into the immune environment of the mucosa, and that stimulates all our T cells, and the T cells then migrate to the epithelium, and we see increased intraepithelial lymphocytes. So this is the tip of the normal villi of the small intestine. Here you can see the tall elongated nuclei which which are somewhat light color. They are actually epithelial nuclei, and the small round dark nuclei, they are lymphocytes. Okay, we have to count in the tip of the villi, and we count the relative number of these dark cells vis-a-vis the columnar nuclei of the enterocytes. Now, if we talk about the intraepithelial lymphocytes in the duodenum, the normal count is 1 IL per 5 epithelial cell. Epithelial cells means we count the nuclei. Now, if the count becomes more than 1.5 to 2 per 5 epithelial cells in the duodenum, that is considered as pathological. But this cutoff actually varies in different part of the intestine. Like in the duodenum, we take a cutoff of more than or equal to 30 per 100 epithelial cells. That is exactly like 1.5 in 5 epithelial cells. However, in the jejunum and ileum, the pathological cutoff is slightly higher. It is more than or equal to 40 intraepithelial lymphocytes per 100 epithelial cells. So we have seen how these intraepithelial lymphocytes are stimulated and they home to the epithelium, and in pathological condition their number increases. So in pathological condition, if we look at the tip of the villi, it will look like somewhat like this. You can see now the number of the lymphocytes have increased substantially. We have to count at least 5 tip of the 5 oriented villi. We'll talk, see what is a oriented villi later. Okay, and we can see the number is certainly more than 1 to 2 per 5 epithelial cells here. While a hematoxylin and eosin stain slide is good enough to count the intraepithelial lymphocytes, some may prefer to do some immunostains like anti-CD3 or CD8 stains, but it is not recommended routinely because while it increases or it helps us to highlight the lymphocytes out of the epithelial cells, but somewhere it has been seen that in studies, if you count intraepithelial lymphocytes on immunohistochemical stain slides, the count may be spuriously higher also. Okay, so you will identify more number of celiac disease erroneously, but then the patient actually have it. Okay, so we did a study where this is a large study in the North Indian population, and we found that in Indian adults, the normal IL count in normal duodenum is about 13 to 14 per 100 epithelial cells. Okay, and the pathological cutoff we have already told, it is more than 30 per 100 epithelial cells. Now, if there is any disease which induces the malabsorption syndrome, so the first thing to happen is the increase in intraepithelial lymphocytes. Now next, what happens? So these lymphocytes actually they causes programmed cell death of the surface epithelium, and this is actually representing the crypt base, where you can see these green cells. They are actually crypt basal stem cells. They are guarded by the Paneth cells in between. This is another kind of stem cell which is called level 4 transient amplifying cells. Okay, now these are the our powerhouse. Whenever there is excess demand, they can now proliferate and they can multiply, they can get matured, and we see and there is unended supply of these enterocytes, goblet cells, and other mature type of cells. So when this is activated, what we see in the next phase, we see the crypt are becoming elongated. We can see longitudinal branching. Now the nuclei has become more darker. There is overlapping and there is slight bluish tinge in the cytoplasm also. So all this together we interpret as crypt hyperplasia. Okay, this is the lineage basically tracing study where we can see these cells are actually proliferating. This is the normal stem cells, and here the cells are proliferating and they're migrating towards the tip of the crypts. And this process takes about varying from maybe 3 to 5 days or 3 to 8 days or so. Okay, this is just to show you an example from one of our studies, just to show you number of the LGR5 positive crypt basal stem cells. Okay, you can see in a crypt they are usually between 3 to 5 in number. However, in celiac disease, when there is increased intraepithelial lymphocytes, what happens? There is increased demand and the LGR5 positive cells has multiplied and the number has increased substantially. Okay, so this is the next important pathological change we see in most of the malabsorption syndrome. So I am giving an example of celiac disease, but it will happen in most of the diseases which induces malabsorption syndrome or small bowel diarrhea. Diarrhea and malabsorption syndrome are not synonymous, but in most of the malabsorption syndrome, there will be diarrhea because of the luminal increase unabsorbed carbohydrate or fat which is coming out, and the water which cannot be absorbed. So this is just to show what happens. So if the patient is sensitized to gluten, what happens? It will stimulate the lamina propria lymphocytes, and the lamina propria lymphocytes on being activated, they will home to the tip of the villi. This increase the programmed cell death. So initially, if I told you the crypt is a powerhouse. It can replenish the loss at the tip of the villi. So initially, when the patient is just sensitized, maybe for 1 or 2 months or 6 months, the patient is still keeping on taking gluten-containing diet, we can still see tall villi despite having increased IELs and crypt hyperplasia. So these early phases, we called it mild enteropathy disease. However, a stage arises when the crypt fails or crypt cannot keep up with the increasing demand. Okay, so when the crypt fails, what will happen? Our mucosa will become flattened, and we see varying degree of villus atrophy or villus flattening. Atrophy is a misnomer. It should not be used. You can use the term flattening, or you can use the term shortening. Okay, so we can see the villi are not seen here. There is crypt hyperplasia, increased IEL. So this phase is called advanced enteropathy, celiac disease, or advanced enteropathy disease. This is in short. And we have seen in our older studies that these increased intraepithelial lymphocytes actually increase the programmed cell death in the surface of the mucosa. Okay, so what we discussed till now, in diseases which causes malabsorption syndrome, including celiac disease, we'll see increased intraepithelial lymphocytes in the surface mucosa. We'll see crypt hyperplasia. It will come next to the increased intraepithelial lymphocyte infiltrate, and later we'll see villus flattening. So we should not forget these three important histological interpretations. However, it is needless to say that these three histological features cannot be specific to any of the disease. That's why you should always remember, especially the postgraduate students, that small intestinal pathologies in diseases of malabsorptions are not specific. I have made a table for you just to show the number of the diseases where you can see increased IEL, crypt hyperplasia, and villus abnormalities. The causes or the etiologies are actually common to all of them, mostly, except villus abnormalities you can in additionally also see in various drugs, like when the patient are taking antibiotics like azithromycin, or immunomodulator like sorry, mycophenolate mofetil or methotrexate, most importantly antihypertensive olmesartan or oral contraceptive pill. Okay, so we should remember in addition that villus abnormality or villus flattening in or without with or without absence of intraepithelial lymphocytes, you should not forget the diseases, the drugs actually which are commonly taken. And if we talk about the diseases where all these pathologies can be seen, the autoimmune diseases we have already mentioned, like celiac disease, it can be seen in bacterial infection, like in tropical sprue, other non-specific bacterial infection. You can see in viral infections. You can see in common parasitic infection, which is very common in Southeast Asia, like in giardiasis. You can see in fungal infection, H. pylori. Actually, H. pylori, the prevalence of infection is nearly about 70 to 75% in North Indian patients. Okay, so it is so common. So before considering a specific diagnosis of celiac disease and others, you should look at the form. You should ask the clinical history, endoscopic finding. Okay, look for H. pylori is there or not. Then only we should come to a diagnosis of celiac disease. Similar findings can be seen in Crohn's disease, common variable immunodeficiencies, and in lymphomas also, because like autoimmune disease, in lymphoproliferative disease also, the basic character of the lymphocytes are to destroy the epithelial cells. So you will see similar findings: epithelial injury, epithelial infiltrate, and loss of epithelial cells. Okay, so we'll come to some of them. But the most important thing is, all this interpretation is only possible when you orient your small intestinal biopsies very well, and the onus doesn't come to you only. Yeah, the responsibility starts with the gastroenterologist, then pathologist, and it lies with your technicians. So you have to be in contact, be in discussion with all of the whole team to basically satisfactorily orient your biopsies. Like, the gastroenterologist should not use forceps, which can cross the biopsies. They should use a needle tip just to separate the mucosal biopsy fragment of the cups. Sometimes they can clearly identify the shining mucosal surface from the submucosa, and by seeing that, they can keep the mucosa towards the face, so that mucosa is facing towards the face, and they should always try to mount the biopsy on a squared filter paper. It can be laboratory grade 1 filter paper. It can be other medias also. It can be cucumber, or it can be other tissue papers. Okay. So if you wait for 10 to 20 seconds, the plasma will coagulate. It will adhere, and then they should drop the filter paper mounted biopsy in the basically container having the 10% neutral buffer formalin. Okay, you all know the at least the volume of the fixative to tissue should be at least 10:1. It should not be fixed more than 6 hours. Okay, if you fix more than 16 hours, what happens? It becomes very brittle, and the tissue loses its antigenicity in case if you have to do some IHCs. So after fixing, you should not dislodge or should not separate the tissue from your basically filter papers. What we do, we put diluted eosin just to make the mucosa dark. Okay, if we still identify the mucosa is well oriented, we just keep the smaller pieces of filter paper in a larger piece of filter paper, and we fold it like an envelope and put in cassette. Now our technicians are trained. They know that the filter paper mounted biopsy, they have mucosa facing towards our face, so that to keep all the layers in the cutting surface, what they do, they rotate it in the 90-degree, and they make the block. Okay, and they get multiple step cuts in single slide. The most important thing is we have to know the sequence. Sometimes the technicians cut multiple step cuts, but the pathologists do not know what is the sequence of cutting. That's why it is a good practice, so that we keep or we take the level 1 cut towards the slide level. Okay, that's why if you standardize this, everybody knows what is the sequence of step cuts, and you can look at the multiple slides, and you can identify the best oriented section to interpret, and you have to mark it so that if there is a need of review, everybody knows where you have made the interpretation or the assessment. Okay, and I am happy to announce that along with the Indian Society of Gastroenterology, IAPM just took up this issue of heterogeneous practice, and we have made the guidelines, and we have made the draft, and it will come in IGPM very shortly. So now this is how under microscope oriented biopsy should look. Oriented biopsy should have the elongated crypts like this. Okay, so elongated crypts, if you see 3 to 4 crypts in a sequence are arranged perpendicularly over the muscularis mucosae, that indicates that that part of the mucosa is well oriented. But you should also know that sometimes the mucosa can be obliquely cut like this, where you can identify the crypts are rounded. Okay, that means they're transversely cut. However, you can identify some long villi. So this is also not oriented. We also do not interpret whenever there is a large reactive lymphoid aggregate, or there is the mucosa has been taken over the Brunner gland, especially when the biopsy is from duodenal bulb. Then in these scenarios, what happens, the overlying mucosa can be stretched spuriously, and the villi can be erroneously or spuriously flattened. Okay, that's why we should not interpret the cryptovillus ratio in these areas, but it is good to look at the intraepithelial lymphocyte in these areas. So you should not forget that in the duodenum, the villi can be slanted. The villus tip can often be looked as fused like this. So here we should not try to interpret the cryptovillus ratio. This is again the duodenal bulb. Okay, you can see here we should not comment on the cryptovillus heights or ratio. And you should always remember that whenever there is a large lymphoid aggregate, on the top of it, you will see there is always some increased intraepithelial lymphocytes. This is not pathological. So the dictum is, whenever you want to count the intraepithelial lymphocytes on the surface mucosa, always leave 3 crypts. and then count the intraepithelial lymphocytes in the area which is away from the lymphoid aggregates. Okay, the duodenal villi often can be denuded. Here you can see one fragment. Okay, you may think that the villi has flattened, but it is not so. See, all the villi are lying here. Okay, it happens if the gastroenterologist, I told you, it should be very soft handling with the tip of the needle. If they use forceps, or if they use harsh basically handling, then the mucosa can be dislodged, and this is the obliquely cut mucosa. Despite having a tall villi, you can see all the crypts are rounded. So I have told you three scenarios. One is best scenario, the crypt is tall and the crypt is elongated and the villi are also tall. And the second scenario is the villi is tall but the crypts are rounded, that is the oblique cut. And the third scenario is it is not at all oriented, when you cannot see even the surface mucosa as well as the crypts are obliquely cut. So I will tell about our experience, that is the spectrum of malabsorption syndrome. This is a couple of years back, we look at our institute prospective study, what is the spectrum of malabsorption syndrome in our hospitalized patients. And we found that celiac disease is the most common cause of malabsorption syndrome, comprising nearly about 65% of our bulk in our hospitalized patients, followed by tropical sprue, followed by common variable immunodeficiency, Crohn's disease, intestinal lymphangiectasia, then Williams syndrome, and idiopathic malabsorption syndrome, where we could not identify any malabsorption syndrome. So now we all know celiac disease is the most important cause of malabsorption syndrome, except some part of South India. I will touch upon that. So celiac disease, we all know that from our centers, there are large studies, including many centers of South India. We found that the prevalence of celiac disease in North India is about 1.04% in adults. In South India, the prevalence is quite low. This is also true for the Eastern India. It is only for 0.3%. Overall, it is 0.7% in India. So you can imagine, in 1.3 billion patients, what would be the load of celiac disease now? And the Asian prevalence is 0.5%. Okay, this is the Asian prevalence. Our student found this in a meta-analysis. And you all know celiac disease is basically a conflict between the gluten, which is present. It is a gluten peptide, which is insoluble, which is patent in the endosperm of the kernel of the wheat. Okay, and it is both toxigenic and it is immunogenic, and the patient develop allergic reactions, and that's why the tall duodenal villi become shortened or flattened like this, and that is the characteristic of celiac disease. And endoscopically, always in the form, you should insist on this fact that the clinician should give you serological value. They should write the endoscopic findings and the clinical presentation to make you understand what is the clinical scenario. So here you can see, these are the fine villi and microfolds you can see here. Okay, but here you can see they are almost flattened. Okay, in addition, there is marbling here, that is also called the scalloping of the duodenal folds. So whenever the gastroenterologist sees like this, they suspect a malabsorption syndrome and or celiac disease, and they take biopsies. Okay, now we have come to the site and number of the biopsy fragments, and it is very convenient to take biopsies with the current endoscope from the second and third part of the duodenum, post-ampullary part, and that is the most commonly practiced. Okay, however, the changes of the celiac disease and other causes of the malabsorption syndrome also similarly can be seen in the jejunum. Okay, but jejunal biopsy is not commonly taken. However, in the initial biopsies in a strongly suspected patients, if the biopsies from the duodenum or distal duodenum is not contributory, then the biopsies can be repeated from the distal duodenum as well as from the jejunum. That often brings out the pathological changes. Okay. Now, to determine the number of the biopsy which are adequate, multiple studies has been done, and it has been seen that if 2 biopsies are taken, then the pathological changes which I have described can be seen in 90% patients. If 3 biopsies are taken, then the changes can be seen in 95% patients, and in 4 biopsies are taken, the changes can be seen in 100% patients. Okay, and However, in the other studies, it has been shown that the sensitivity of identifying the pathological changes, the 3 cardinal pathological changes I described, it reaches to 100% only when when at least 1 to 2 biopsy fragments from the duodenal bulb are added with the biopsy fragments from the distal duodenum. Okay, that's why the current recommendation for taking duodenal biopsy is at least 5 to 6 fragments. If it is better that all biopsy fragments are separately filter paper mounted and they are separately leveled in different containers site-wise. Okay, so what we told, 2 fragments each from the second and third part of the duodenum, and at least 1 to 2 fragments from the duodenum. And why duodenal bulb is so important? Though we have told that the villi can be spuriously shortened, it has been seen that in 10 to 15% patients, the changes of celiac disease, can be solely limited to the duodenal bulb. Okay, so if you cannot sample the duodenal bulb, so you may not or you may basically you may not identify the pathological changes in up to 40% of the patients. Okay, so that's why it is important. Just to show you an example from our patients, this is the duodenal bulb biopsy. These are the biopsies from same patient, distal duodenal biopsy. Here you can see the pathological changes are not there. Yes.
Thanks, sir. I have muted
Okay,
myself.
okay, sorry. So you can see there is no pathological changes in the distal duodenum, but in the distal duodenal bulb, you can see there are pathological changes of celiac disease like increased IELs. Okay, so that's why duodenal bulb biopsies are so important. So I told you one of the important finding in celiac disease is the ileolosis, that is increased IEL in the tip of the villi. And I told you in celiac disease that the increased intraepithelial lymphocytes is most reliable if you always look at the tip of the villi, that is upper 1/3 of the villi. Why? Because it has been seen that in normal physiological condition, the upper 1/3 or 2/3 of the mucosa is actually exposed to the luminal content, and the lower part of the villi and the crypts are actually exposed to the luminal content when there is a pathological dilatation of the small bowel. Okay, that's why if you count the intraepithelial lymphocytes in the tip of the villi, that always represents the pathological condition. And I talked about the utility of the basically immunohistochemical stain. You can only use immunohistochemical stain when there is the IL count is borderline or it is not high, maybe around 20 to 22, but clinically it is, possibility of celiac disease is strongly suspected. Then you can do immunohistochemical stain just to highlight them and recount again. And we all know in celiac disease, the CD4 cell count increases, CD8 cell count increases as a IEL, and most of the IELs are actually gamma delta type of T cells. So this is just to show you what is the pathogenesis of basically celiac disease. And I told you the glutamine or the gluten peptide, which is very resistant to digestion by the pancreatic or gastric or intestinal juices, and that cannot be digested. And when that enters into the immune environment, what happens? There is transglutaminase 2 enzyme which is present in all our tissue. It is a normal enzyme present inside the cell. Okay, what it does, it causes cross-linking of the this enzyme with the gliadin peptide. Okay, so that's why there is a glutamyl lysine bond is formed, and these two together joins. Okay, and for this becomes a new antigen. So in the enzyme, which was a normal part of our body, now on being linked with the or bonded with the gliadin peptide, now becomes antigenic. Okay, another thing, but this enzyme also causes deamidation. Deamidation, due to deamidation, what happens? The glutamine now becomes glutamic acid, and glutamic acid has high negative charge on its surface. So due to these confrontational changes as well as increased negative charge on the surface, it now binds strongly to the HLA-DQ2 and DQ8 type of receptors. The patients which have this type of HLA haplotypes, they are highly sensitive to the celiac disease. This is the cause, and that stimulates the CD8, CD4 type of T cells. Okay, so they releases interleukin 21. Interleukin 21, on the other hand, stimulates the CD8 type of cells. They migrate or home towards the surface epithelium, and the surface epithelium, on being injured, they become interleukin 15, and that produces a vicious cycle. Okay, now when the TTG2 and the gliadin forms a new antigen, or it combines each other and forms acts like an antigen. So what happens? Antibodies are formed in our serum or in our blood and circulates against them, like anti-DGP antibodies, anti-gliadin antibody, anti-TTG anti-2 antibody. That is actually the basis of serological screening in celiac disease. And since 1990s, many sensitive serological tests have been or kits have been introduced. We all know commonly we use tissue transglutaminase, basically IgA type of ELISA kit, and that has very high sensitivity and specificity. But we should always remember, in a highly suspected patients, when IgA type of ELISA is showing is not showing high titer, we have to look also at the IgA level of the patient, because the patient can be IgA deficient. Then we have to use IgG type of anti-TTG test, or we can use anti-endomysial IF immunofluorescence test, or we can use multiple combination of the serological test. And IgG DGP is very sensitive in this scenario when the patient is IgA deficient, especially in children, to pick up if the serological titer is high. So if biopsy is important, because especially in children, the ESPGN says that if the children is young, you can do with serology only. If the anti-TTG serology is 10 times than the normal, and if the patient, another type of serological test like GGP or anti-endomysial antibody is also positive in a second sample, and if you can do HLA typing and the patient is HLA-DQ2 and at 8 type, then you can diagnose celiac disease. Okay, now BSG also incorporated or admitted this criteria only, with some exceptions. They have not advocated HLA typing. For adults, they have said that biopsies is all required in adults. A serological test also has been advocated by the World Gastroenterology Organization. However, if you look at the other recommendation by the American College of Gastroenterologists or the Indian Council of Medical Research, India, in adults especially, biopsy is mandatory. It is believed that if the children is more than maybe 5 years of old, then similar findings and similar endoscopic findings and false positive serological test, the possibilities are quite high. That's why biopsy is mostly favored. And I told you what you have to see: increased IEL, crypt hyperplasia, and the crypt hyperplasia and villus flattening. So based on this, you all know this is just showing you the modified Marsh grading. In the Marsh 0, everything will be normal. The crypt to villus ratio, you all know, it is about 1:3 to 1:5. In India, it is between 1:2.5 to 1:3. Okay, that is the IELs are not increased. In March 1, there will be only increased IELs. In March 2, along with increased IELs, there will be crypt hyperplasia. In March 3, there will be villus flattening. Okay, now Marsh and modified Marsh describe the villus flattening qualitatively as mild, moderate, and severe. We basically modified this just to increase the inter-observer agreements. We said that the crypt to villus ratio, if it is less than 1:2, but if the villus height is still taller than the crypt depth, it is 3A. If the villus height and crypt depth are almost equal, that is 1:1, it is 3B. And if the crypt depth is more than the villus height, it is 3C. And it works very well in our scenarios. Okay. So now we can, there is, there is no laboratory test to diagnose celiac disease. However, we identified this laboratory test, that is to identify IgA anti-TTT deposit both in the intestinal biopsies as well as extraintestinal organ, just to identify if they are representing celiac disease. And you can see the green colored the positivity is representing IgA, and the red positivity is for TTG, and the yellow color is the colocalization. This colocalization is indicating IgA anti-TTG deposit. You can see in a patient with celiac disease, the IgA anti-TTG is also deposited in the small intestine, along with being circulated in the blood in the subepithelial basement membrane. You can see the basement membrane is highlighted in the capillaries, in the lamina propria. These are mostly capillaries, as well as they are deposited in the muscularis mucosae. This is actually the confocal microscopy. We very rarely do, unless we need to do for studies, anti-endometrial immunofluorescence test. This is not very cumbersome, and this is a basically indirect immunofluorescence test indicating positive and negative test results. Now I will show one biopsy and will tell you how to identify or how to go for interpretation. Now you can identify the muscularis mucosae. You can see tall crypts, so most probably this is oriented. Now before, so how to identify orientation? I told you, you have to identify perpendicularly oriented at least 3 to 4 crypts in a row to call that part oriented. So we think this part of the mucosa is oriented. Next thing, we have to draw a line which actually representing the villus and crypt junction. This is called the shoulder of the biopsy. You have to imagine this line, and then you have to measure imaginary lines to from this line actually to measure the crypt depth and the villus height. In this case, it is the villus to crypt ratio is almost 1:1. We can identify increased IEL and crypt aplasia always is there. So according to our criteria, it is MARS 3B. However, always remember, we cannot diagnose celiac disease just based on histological finding. As I told, the histological changes are non-specific. So if you don't have clinical criteria findings on form, you don't know serological titer, endoscopic finding, you have to write it is a moderate villus abnormality. Moderate because it is 1:1 with increased IELs and crypt aplasia. If you know serology, you will just say it is consistent with the diagnosis of celiac disease, and then you have to give modified Marsh grade 3B. You should remember that clinically it may not be important for treatment of celiac disease to grade the biopsy, okay, but it is a very good idea to grade the biopsy because if the patient has to be followed up, okay, on follow-up biopsies, maybe after 12 months of GFD or 6 months of GFD, if you want to compare how the mucosal changes have regressed or progressed, then you have to know what is the modified Marsh grade in the initial biopsies, okay. So that's why grading is a very good practice, and you should do it. And there are other histological grading system which came after the modified Marsh grading came in 1999, like Corazan, Vilanci, and Ensari histological grading, almost same as the Marsh grading, but they were also qualitative. They also told mild, moderate, and severe villus flattening, and that is the reason for the very low intra-observer and inter-observer agreements. Just see, the inter-observer agreement is less than 50%, okay, in diagnosis the pathological changes of celiac disease. So we undertook a Q histological grading system study, and we described this basically classification system. I only just want to highlight that the current IELs across the countries, I am also part of a multi-center study all over the world, and they found that the current IEL cutoff, pathological cutoff, is more than or equal to 25 per 100 epithelial cells. We also found in independent study in North India, but we will not advocate at present unless further recommendations come. So you should stick to the pathological cutoff of 30 or more than or equal to 30 per 100 epithelial cells. This is a very good Q histological grading system which increases the inter-observer agreements up to multiple folds, but this is a very time-taking procedure. So unless we introduce some automated or basically artificial intelligence based automated application of this Q histological system, it may not be very practical to use routinely. Another thing you should remember that the grades, what we are doing, that not necessarily present the severity of the disease, because it doesn't correlate well. See, these are the different marsh grade. IL counts are not increasing. This is our study, and this is that multi-system study I was mentioning. And across the different modified marsh grade, you will not see the ILs are sequentially or increasing. Okay, so increasing pattern is very unequal. So that's why it doesn't actually indicate the severity of the disease. Now, very briefly, tropical sprue. Tropical sprue is very prevalent also nowadays in South India. In villages, it is very common. And if you look at the South Asia, it still comprises of 40% of the cause of malabsorption, both in children and adults, in basically in patients with malabsorption. And a few decades back in North India also, tropical sprue is the most common cause of malabsorption syndrome. And we don't identify what is the actual cause of tropical sprue. However, various pathogenesis like bacteria or parasites or viral pathologies have been suggested, including some form of coronaviruses, E. coli, Klebsiella, etc. Okay, and it is also called traveler's diarrhea because after traveling to an endemic zone, patients commonly acquire these diseases. The histological features, as I told, is almost same. Like IEL will be increased, crypt hyperplasia will be there, and there can be virus flattening. There are subtle changes. Like in many cases of the tropical sprue, the increased intraepithelial lymphocytes you will see in the middle third or in the lower third of the villi, more than the upper part of the villi. So in celiac disease, I told you, you have to always look at the upper one third, and this is called the decrescendo pattern of the increased intraepithelial lymphocytes. Okay, this you should keep in mind. But in tropical sprue, you will also see increased intraepithelial lymphocytes in the surface. So in many cases, you will see decrescendo pattern of increased intraepithelial lymphocytes. And if you compare 100 patients of celiac disease and 100 patients of tropical sprue, the severity of the villus flattening will be more in celiac disease. I mean 3C and 3B changes will be more representative of celiac disease than in tropical sprue. Okay, in tropical sprue, most of the villus flattening is mild to moderate. Okay, you should keep that in mind. And I told you, this is also called traveler diarrhea. Most patients develop diarrhea, and about 80 to 90% of them, but the diarrhea goes or it is cured automatically. However, the patients 10 to 20% who have persistent diarrhea, the dictum is they should undergo mucosal histological changes or fat estimation in the fecum, and other tests for the malabsorption syndrome like D-Gylose test, etc. And if any one of these tests show abnormality, including histological changes, then you can diagnose it in the tropical sprue. So tropical sprue is a persistent form of traveler's diarrhea, just to summarize. So we did a meta-analysis, and we tried to see what are the endoscopic and clinical features which are different between these two diseases and help us to diagnose, because histological features mimic. We found that only severity of the villus abnormality, both endoscopically and histologically, are much less in tropical sprue. Okay, and ileolosis, the decrescendo pattern, is not a feature very common in celiac disease. Decrescendo pattern is common in tropical sprue. And if you count eosinophils in the lamina propria, in celiac disease also you will see eosinophils, but the average count is about 14 per high power field. On the tropical sprue, the eosinophil counts are actually more. But I don't know how this criteria can be applied in a particular case in practice. Okay, but there are certain changes. Just to highlight, as the IELs in the tip of the villi are much less, so in celiac disease, where we see the flattening of the epithelial cells because of the injury, in tropical sprue, the epithelial cells are still tall columnar, we most commonly identify. Now, third most common cause in our scenario is the common variable immunodeficiency, and it is one of the commonest cause of basically immunodeficiency in European countries. But in our cases, countries also, we see a lot of cases, especially in adults. It can affect the children also. It has a wide age range of presentation. Okay, the presentation can be varied, including GI manifestations can be seen up to 20% patients of CVID. Okay, and diarrhea and malabsorption can be seen up to 50% patients. Now, most important thing, you should always keep in mind that you never forget to keep a differential of celiac disease, tropical sprue, and CVID when you see these three histological features I talked about, because the sprue-like changes is seen in about 50% cases of CVID. That is, will just show you increased IEL, crypt hyperplasia, and villus flattening. Okay, so here I am showing increased IELs, crypt hyperplasia, neoplasia, okay? And due to immunodeficiency, you can see parasitic infestations. This is Giardia parasites, okay? And in many cases, you will see in addition, there will be dense infiltrate of polymorphs along with cryptitis, just like your IBD. That's why it is also called CVID colitis. So in CVID, we see this type of features like sprue-like or CVID colitis-like features. But always remember, neutrophil, though, is not a very common feature of celiac disease. In severe celiac disease, you can see also neutrophils in lamina propria. And third common histological pattern in CVID is large reactive lymphoid follicles, multiple in the mucosa. So the dictum is, if you see too many reactive lymphoid follicles both in the mucosa and submucosa, so you have to always keep in mind, keep a possibility of celiac disease, in CVID, okay? But how to reach to a diagnosis? Obviously, we'll ask your clinician colleague what is the immunoglobulin level. But at your level, you can go into high power and look for the plasma cells. Normally, plasma cells is always and always present in most of the infectious conditions of the small intestine. But here, plasma cell deficiency, lack of plasma cell is the feature, okay? Here you can see so many plasma cells in celiac disease and tropical sprue. However, they are absent in CVID. Or you should always remember, if we take a distal biopsies, distal intestinal biopsies, like the paucity of plasma cells commonly seen in a very few cases of esophageal biopsy, but they are more common in duodenum. However, they are more commonest in the distal small intestinal or colonic biopsies, okay? So you have to basically talk to your clinicians regarding that. Now you can do CD38 or 138 to highlight if you are seeing paucity of the plasma cells, and you can see also paucity of the CD4 cells in cases of CVID. I'll skip this, and just to highlight again that these three histological features are not specific, okay? And tropical sprue, we have seen there are subtle changes, subtle differences, and in CVID also the differences are very subtle. I will just quickly show you some examples. Like these are all biopsies showing very dense inflammation, including neutrophils. I am just trying to show you if you see different combinations of inflammatory cell, what you have to think. If you think, see neutrophil, what I told you, neutrophil you can see in CVID colitis, neutrophil can be seen in severe celiac disease. But if you see neutrophil too many, you should not forget three conditions. One is autoimmune enteritis, second is H. pylori induced changes, and third is Crohn's disease involving the small intestine. Okay, you should never forget. Here I am showing you examples of H. pylori induced duodenitis. You can also see eosinophils in these conditions, and this is one of the example of ours just to show. This is broadened villi, numerous infiltrate, many eosinophils along with polymorphs. So if you see eosinophil polymorphs, always keep this in mind because this is actually representing a Crohn's disease involving the small intestine. Okay, now if I am talking about the eosinophils, if you see too many eosinophils, you cannot identify any other cause, you cannot identify parasites. Okay, you should also keep a possibility of eosinophilic duodenitis, because these patients can also present with diarrhea or malabsorption syndrome. So but it is a diagnosis of exclusion. You should mention there is mucosal eosinophilia. It is the job of the gastroenterology colleagues to look at the stool findings for parasite, to look at the serum Ig level, or to look for the absolute eosinophil count before reaching to this diagnosis. Okay, now this is a duodenal biopsy. What we can see, there is increased IELs here and there at the tip of the villi, and you have to also look at the surface of the mucosa. Here you can see multiple trophozoites, and you should not forget to look for parasites. So in your report, always make sure there is at least negative comment regarding the parasite present or not. Okay, so these are parasites very commonly seen in our conditions, and this is another condition along with CVID where you can see occasional reactive lymphoid aggregates. Lymphoid aggregates can also be seen in H. pylori infection. Okay, so you should keep this in mind. This is another common clinical conditions. The mucosa is nodular, and you can see the broadened villi, and there is numerous plasma cells. Okay, there is increased lymphoepithelial lesions, there is increased IELs, and if you do IgA level staining, all these plasma cells will be positive. but this IgA is actually cryptic IgA. Okay, but they have a typical genetic change. That's why these patients have, though have serum IgA level, their short chain is abnormal. Okay, and here basically this is a case of IPSID, immunoproliferative small intestinal disease. In this case, also histologically, you can talk to your clinicians that I am seeing too many plasma cells with increased IELs, increased lymphoepithelial lesion like a maltoma. Maltoma actually, if it is a IgA secreting maltoma, just to keep in mind. Okay, they should do immunofixation study just to see if there is M-band or serum IgA level also should be looked for to correlate all these findings and to reach to a diagnosis of IFSID. This is not my case. I have not encountered any case, but this is very common scenario. Olmesatran, antihypertensive induced villus flattening. In these cases, the serology will be negative, IELs can be increased, and this is the delayed type of immunity, and interleukin induced changes, interleukin 15 induced changes. I told you common antibiotics like azathioprin can also cause villus flattening. So if you, before biopsy, if you stop the antibiotics or OCPs for 7 days or so, you can avoid this type of spurious changes. However, in olmesartan, these changes takes a long time to develop and long time to go, nearly about 3 to 6 months. So there is no advantage of basically temporary withdrawal of the medicine. But you should always forget in olmesartan and antibiotics and OCPs can produce very similar changes like celiac disease. I will just highlight very quickly some scenarios where small intestinal biopsies can be very diagnostic. So don't think that small intestinal biopsy is not important. It is important to establish a diagnosis of celiac disease, to important to rule out any other disease like giardiasis or coexistent diseases. Okay, but in these conditions it is diagnostic. Like this patients, this is a 2-month-old male presented with intractable diarrhea. We found crypt hyperplasia and villus flattening. We thought, can it be celiac disease? But there is the patient is just 2 months old. There is no weaning. So how can this patient develop celiac disease? So always in intractable diarrhea in a very small child, you should look for other developmental or anatomical malformations. When you looked at the surface of the mucosa, see what we can see. We can see structures like this. They are called tufts of epithelium. Okay, they are actually jumbling up. There are multiple tufts. Okay, this is one of the developmental malformation. In the same patient, we could also identify this type of tufts in the colonic biopsy also. So this, if there is tufting like this, what happens? The paracellular junction, I showed you electron microscopy in our cases, that is actually obstructed or due to jumbling up. Okay, so absorption cannot takes place. So these patients presents with diarrhea secondary to malabsorption. And in these cases, you should always know two common genetic defect in these conditions. One is mutation of the EpCAM gene. So if you do EpCAM, basically immunohistochemical stain or MOC31, the same stain actually, you will see there is a loss of EpCAM protein due to this mutation, and you can establish the diagnosis. Okay, in our case, we also sometimes do electron microscopy when it is needed. In tufting enteropathy, we commonly see, along with dysuria of the microvilli, we can also see duplication of the desmosomes. The number of the desmosomes increases multifold, like what I am showing you. Okay, this is example of another infant. She also presented with intractable diarrhea. We found the mucosa is normal or the biopsy is normal, and there is some non-specific inflammation. There is no villus flattening. There is no increased IELs. But when we looked very carefully after talking to the clinician, because what is the cause of the intractable diarrhea? Always remember, if you look very carefully, you can identify the microvilli like this. See, in this area, you can identify the microvilli even on H&E section. You can also do pass width diastase stain just to highlight the microvilli. It should be continuous layer like this. But in this condition, you can see there is lack of microvilli in a majority of the mucosal surface. Okay, microvilli normally should look like this on electron microscopy. So after staining, what we found that you can do Villen stain or CD10 stain also, just to highlight the microvilli. Normally they should be positive, like a linear positivity on the mucosal surface, not inside the cells. But what you can see in this case, the positivity is actually at the tip or at the apical surface of the epithelium. Here you can see the positivity is not at the surface, at the apical surface, at the apical area or of the cytoplasm of the enterocytes, and you can see some nodular structures. Okay, this indicates that microvilli are not exposed to the surface. That's why this disease is also called microvillus inclusion disease. Here you can see on high power the same case. You can see the positivity is inside the cell cytoplasm. Here also it is inside the cell cytoplasm, and you can also see this type of vesicles inside in some of the apical surface of the cytoplasm. Okay, if you do electron microscopy like what we did, you can identify these abortive or abnormal microvilli inside the sac, which will be present inside the apical surface of the cytoplasm. Okay, this is just to confirm the diagnosis, just like a blister, because in these patients this gene mutation has commonly been described, myo5b. These are responsible for, basically they are formed inside the cytoplasm only. Okay, and they are migrated towards the surface. However, due to this gene mutation, they cannot migrate or expose to the surface. Okay, so you can see only few microvilli on the surface, and there will be abortive. Yes, so this is a diagnosis of microvillus inclusion disease. So if you find on form intractable diarrhea, that means severe uncontrollable diarrhea in a infant, you should always look for microvillus inclusion disease or tufting enteropathy. There can be though other causes like milk protein allergy. There can be celiac disease, obviously after 4 to 5 months or after weaning, and there can be some other enteroendocrine abnormalities also, which can cause deficiencies in these conditions. I'm showing a very rare cause of malabsorption what presented in our routine practice. What you can see, I can see this part is denuded. There are some villi here, tall villi, crypt hyperplasia is there, but there are some eosinophilic structures like this. Initially we thought, can it be amyloid? See, this is extracellular and present mostly in the lamina propria, okay, nodular aggregates. And when we did congodate stain, they were not congophilic, okay. And when we did kappa and lambda stain, they were capital basically restricted, and IgM was strongly positive and others were negative. So this is an example of duodenal macroglobulinemia. Always remember, this can be seen. Also amyloidosis can be seen, but these deposits are usually not seen on the vessel surface like amyloidosis. I forgot to keep a picture of that. Okay, and we do see amyloidosis of the duodenum, which may present with diarrhea and malabsorption syndrome. Very rarely you can see case reports, very occasional case reports of Waldenstrom's macroglobulinemia presenting in the small intestine, like in our case, okay, which is presenting with diarrhea and malabsorption. In post-transplant setting, you can see malabsorption and diarrhea in patients due to various causes, and your small intestinal biopsy is instrumental, okay, where you can see the crypt-villus ratio is increased. There is no increased IELs, but neutrophils is increased along with other cells, okay, and what you can see, there are multiple small basophilic rounded structures sticking to the mucosal surface. Okay, so these are actually cryptosporidiosis. In the same patient, there was also some inclusions in the endothelium. Hence, we diagnosed this case as both cryptosporidiosis and CMP. Okay. This case is showing you microsporidia inside the cytoplasm, small structure surrounded by a small halo. Okay, so sometimes we may miss this if we don't look very carefully. So always ask if there is in the form there has written there is diarrhea, there is malabsorption in a post-transplant setting. Always ask for the stool finding, what they have found, and look very carefully at your biopsy just to rule out all this. Okay, this is another post-transplant renal transplant related biopsy where we could identify the normal villi, no IELs, but see in the Brunner gland, there is multiple inclusions like this with cytomegaly. So these are positive for the CMP antigen. Just one tip for the postgraduate is that in my experience of maybe 15 years, so what I found that CMP infection in the duodenum is most commonly identified in the Brunner's gland. I don't know why, along with endothelial cells. So if it is suspected, always look for the inclusions and cytomegaly in the Brunner gland. Okay, and you can see in another case we can see confluent necrotizing granulomas and AB positivity. This is actually tubercular reactivation. This is another post-transplant case where you can see sheets of foamy histiocytes. It is another dictum. If you see too many foamy histiocytes with some basophilic tinge, you should keep few differential diagnosis. But we did, to rule out one of them, we did AB stain, and see these are packed with AB. So this is basically a Mycobacterium AVM complex, okay, infection in a renal transplant immunocompromised setting. Should not forget that. In post-transplant setting, you can also see strongyloides hyperinfection. Yeah, but not only post-transplant, in a patient with rheumatoid arthritis taking steroid for the long time, you may identify this type of strongyloid deep hyperinfection. That means these trophozoites are going deep inside the crypts and destroying them. Okay, that is called hyperinfection. In this setting, it is very common. And post-transplant diarrhea is also very common due to GVHD. GVHD is very common after BMT transplant. You all know it is less common in after solid organ transplant. In our cases, what we look for in lymphocytic infiltrate, we look for if there is mitotic count has increased. We look for the evidence of destruction. We look for apoptotic bodies like this. Okay, multiple apoptotic bodies inside the bean bag. We look for in low power if the crypt is lost in over long area ulceration and necrosis are present or not. Okay, what you can see, the crypts have been destructed in most of the areas, and the apoptotic bodies are clumping in the zone where crypts are lost. This is called apoptotic abscesses. And somewhere the neuroendocrine cells are not destroyed. Okay, so neuroendocrine cells remain. This is called neuroendocrine cell clusters. Very commonly you can see some apoptotic body and increased eosinophil count if the patient is also taking mycophenolate, phenolate, mofetil as a part of the regime of the immunosuppression. In those cases, so you should not forget a CMV infection where you can see similar changes, and you should not forget MMF induced changes before calling it GVHD. You should talk to your clinician. So GVHD changes in post BMT transplant you can commonly see in the GI tract as well as liver. It is not uncommon, and we grade the changes based on if there is occasional apoptotic body in one of the crypt, that is grade 1. If a single crypt is being destroyed, that is grade 2. If there is an ulcer or crypt destruction in a part of the mucosa, that is grade 3. And the larger part of the mucosa or the mucosa undergoing necrosis, or there is a large ulcer, that becomes grade 4 histologically. So this is GVHD. This is just to show you one example where along with GVHD, we also found CMV inclusions. So these are not uncommon in post-transplant setting, malabsorption and diarrhea. This is another very common condition you will encounter in post-transplant setting. There are lumpy bumpy mucosal lesions. They have taken biopsy and they are thinking if it is PTLD, like IFSID. So in this scenario, they will ask you if it is IFSID and PTLD. Okay, like see, like IFSID, what you can see here, the broadening of the villi, and there is a lot of lymphoid infiltrate along with plasma cells. CD38 is strongly positive. So what we commonly ask them, first tell us the serum IgA level. If it is very high and immunofixation is high, there is a showing band, then we consider a possibility of IFSID. Okay, so only histology is not diagnostic. Then we also do immunofluorescence for kappa lambda. If we don't see any restriction, if you see restriction, that make you to think that it can be PTLD. In this case, lambda chain restriction was found, and we make a diagnosis of polymorphic type of PTLD. So you should treat your small intestinal biopsies with some more respect, because it can give you diagnostic clues. This is another common scenario where small intestinal biopsy can be very instrumental. This is slightly old biopsy. I am sorry for the color change. You can see large ulcer, flag-shaped ulcer. There are some neutrophil on the surface. However, the base of the ulcer was showing sheets of histiocytes, and these histiocytes are showing numerous hemophagocytosis. This is actually a typhoid ulcer. This patient presented with diarrhea followed by perforation, okay, history, and this biopsy was taken from the perforation margin. So we diagnosed it as typhoid ulcer and perforation. So these are another common scenario. And very commonly, you should not forget this. You can get some small intestinal biopsy, and always the clinical differential diagnosis is it Crohn's or it is tuberculosis. There can be some stricture. Here you can see this low power biopsy. They are showing very focal increased density of inflammation, focal ulceration, focal distortion. Here you can see dense inflammation in the submucosa. This part is ulcerated. You can see numerous neutrophils. I told you, if you see numerous neutrophil along with eosinophil, you should think think of Crohn's disease, but that is not always true. You can see also similar finding in tuberculosis. See the ileal villi, they have been flattened. There's a lot of inflammation, and we can see some small micro granuloma in the mucosa. This is one of the villi. Okay, so even we see this, we just call it, this is chronic active ileitis. We cannot differentiate between Crohn's and tuberculosis, though these type of small microgranulomas are more common in Crohn's disease. If we see large necrotizing confluent granulomas both in the mucosa and submucosa, they favor tuberculosis. But if we don't see them, it is impossible to differentiate histologically. Always keep in mind. So just to summarize, the biopsies in most of the conditions in the malabsorption syndrome can help you to establish the pathological changes. It may not be diagnostic, but in some cases it is diagnostic. I have shown you all examples. There is a luminous, so all these are basically mucosal phase of malabsorption, okay, where the mucosa is altered. But the luminal causes of malabsorption we cannot rule out. We cannot, how can we say if there is deficiency of the pancreatic enzyme, or if there is deconjugation of bile salts due to bacterial overgrowth in the lumen, okay, we cannot tell them. And there are some causes of malabsorption where the absorption is okay, but the transport and processing of the nutrients is problem, okay, then also the biopsies can be helpful. Like I am showing very quick examples. This is one of the frozen sections in our routine cases where the duodenum is showing lot of fat droplet in the surface mucosa. Whenever you see this type of fat droplet, just confirm it with Validosten on your frozen sections. We can see this, and then what you have to think of, you have to think of abital hyperproteinemia. Only dictum is you have to also remember that after a fatty meal in the previous night, this type of fat droplet can be seen in normal person also. So if the patient is suspected of abital hyperproteinemia, the clinician should ensure that the previous night no fatty meal was taken. So what happens in abital hyperproteinemia for the resident? I will just say, you all know that for fat containing diet to transport into the lacteals, the chylomicron has to be formed inside the cytoplasm of the enterocytes, and for formation of that you need cholesterol, cholesterol ester, phospholipids like apolipoprotein B100 and B48. In abital hyperproteinemia, these are actually deficient, so chylomicrons cannot be formed. So as a result, what will happen? Absorption is okay, but all this fat droplet will be stored in the cytoplasm, and that is the histological diagnostic sign. Okay, that is, I will show another condition where the transport is defective. You know, all these things has to be transported into the lacteals, but what if the distally the lacteal is malformed, there is obstruction? So what you will see proximally in the mucosa, the lacteals are dilated. So this is called lymphangiectasia. So these are all our endoscopic finding. What our clinician has seen in both of these cases, see, there are many spots in the mucosa because of the dilated lacteals. So never ignore their findings. Okay, so whenever they see, they put a diagnosis query lymphangiectasia, and sometimes it can be very focal like this. Okay, and I explained what is the cause, and these are one of the examples of our cases where you are seeing large dilated mucosal lymphatics suggesting or consistent with lymphangiectasia. This is another very rare case of ileum where the patient actually presented with recurrent bleeding and malabsorption and diarrhea, okay, for long time. Actually this was recurrent, and you are seeing resected ileum. What you can see this dilated abnormal blood vessels and multiple dilated lymphatics. This is an extremely rare condition. This is a malformation, okay, and this is called lymphangio or hemangiolymphangioма. You can do D240 stain or CD34 stain to highlight them. And everybody knows Elizabeth Montgomery, and she basically reported 12 of such cases of hemangiolymphangioma of the intestine. And you see most of these lesions are seen in the small intestine and few in the colon. We also found 3 of such cases in the small intestine. We get very less time to write case reports, okay, but you can see this type of cases, and most patients present with gastrointestinal bleeding, anemia, and they can also present with diarrhea and malabsorption. So always remember, look at the mucosa, below the mucosa also for the possible cause. This is another example. This poor patient was roaming here and there in hospitals with diarrhea since 10 years and malabsorption, okay, for 10 years. He was treated in multiple hospitals. He came here, the biopsy, our attention was drawn when we found this type of foamy eosinophilic granular cytoplasm. These are multiple histiocytes in the mucosa. we did pass with diastase and they were highlighted very strongly. These are actually granules positive. We did electron microscopy, we found this type of bacilli. This is actually a representation of Whipple's disease or intestinal lipodystrophy. Okay, Whipple's disease you should not forget. So what I told you, if you see too many mucosa, you should not histiocytes in the mucosa, you should not forget. One is obviously muciphagous, you can confirm that, AV plus 10, Alcin plus 10. You should not forget in immunocompromised patients, Mycobacterium avium infection or even tuberculosis. And you can, even in immunocompetent patients, you should do pass with diastase test just to highlight or rule out an Whipple's disease. Okay, very commonly people do some mistake by seeing these type of islands. They think these are histiocytes in the mucosa. These are actually crushed Brunner gland. You all will agree, you will see very commonly this type of artifact. These are normal mucosal gland, you can see the perimeter. These are actually crushed Brunner gland. So if you have any confusion, you can also do pass with diastase 10. They will not show granular positivity. This part will be diffusely and strongly positive. This is a misnomer. Just to show you, this is also a small infant presented with diarrhea since birth. Okay, and we thought, can it be diarrhea of intractable disease, many causes of intractable diarrhea, like what I have showed you, MVID or enteroendocrine deficiency or hyperplasia or MVID. So routinely we always uh, do all this workup. See, we found cryptoplastia. The villi was mildly blunted, but there was no IEL. There is mild inflammation. So we did EPCAM stain. They were present. We did enteroendocrine markers, chromogranin. They were present, not deficient. MVID was not identified. While we were working up, the pediatric gastroenterologist called me, and he told, he found a very typical history that when the patient is off lactose containing milk, then there is no diarrhea. So finally, a diagnosis of lactose intolerance was made. So what I want to tell, that histology may not give always a diagnostic clue, but it is very important to treat your small intestinal biopsies patiently and complete the workup. Okay. Now, this is my take home message. I exceeded time, maybe 10 or 15 minutes. I'm sorry for that. So the take home message is that histological changes of malabsorption are mostly non-specific. I'm stressing this multiple times, since interpretation should be only done after you correlate it with clinical finding, endoscopic finding, serological finding, and then histological finding. Histological examination in celiac disease is not diagnostic, but it helps to establish the pathological changes in the mucosa, and that not essentially indicative of disease severity. Is that clear? In some scenario, biopsy of small intestine also can give you vital diagnostic clue. I have shown you many examples, and you need to work them up diligently. Knowledge about the disease duration, preceding gastroenteritis, systemic features of immunodeficiency are must for the pathologist. Our gastroenterology colleagues should supply us all with these relevant clinical informations. For assessment of duodenal pathological changes, always you should remember 4 to 6 mucosal biopsy fragments, mostly from the distal duodenum, including at least one fragment of the duodenal valve, should be sent to the pathology laboratory after filter paper mounting. Free floating biopsies which are not filter paper mounted also can be satisfactorily oriented by a very senior technicians by seeing the contraction pattern. What happens usually at the deeper part of the mucosa, there are muscularis mucosae, so that contracts, and that's why in a contracted discolored fixed specimen, what happens, the senior technicians can identify on the convexity, they identify the mucosa will be possibly on the convexity, and on the concavity there will be the deeper submucosal part. So by that knowledge they can orient it, but that is not good. Along with celiac disease, possibilities are tropical sprue, CVID, other infectious pathologies, lymphangiectasias, and histiocytic disorders. Crohn's disease, obviously, you should not forget. Okay, and I am happy to announce that our guideline on small intestinal biopsies are coming, and this is a very giant task. We followed all the international norms, and it will come in IGPM within a few months expected. And I think we all work together standardize our practice all over the country. And I request all of you to teach your technicians accordingly, and we should strive to make our practice and reporting format everything uniform. So before I complete, so this is my institute and this is my team. I chose this slide photograph basically I am looking young, that's why. This is my mentor, Dr. Siddharth Dattagupta. You all know sir has just retired. This is Professor Govind Makharia. Without him we could not do all these studies in small intestinal biopsies. He is a phenomena in celiac disease, and there are other faculties in Pramama department and from gastrology. I am thankful to all of you. So if there is any question, I will be happy to address them. So thank you, and sorry for being late.
Forum is open for any queries, questions. Either the delegates can post it in the chat box, or you can unmute yourself and express your queries to the speaker.
Thank you so much for such an excellent presentation, and congratulations for your Herculean task of standardizing the guidelines. And
thank you so much, ma'am. Thank you so much. So it was a pleasure actually.
So far, there are no any questions.
Interesting and very unusual cases. These are some of the entities we just come to see for the first ever time actually.
Yeah, because I practice GI pathology and liver pathology, and I always get angry when I see my residents and other faculties just throw small intestinal biopsies very quickly during reporting, and they think it is not important. So only the thing is, obviously, most of our patients are referred, and they have very unusual diseases. And also it is important to look at the small intestinal biopsies very critically. That is the basically important.
Thank you for accepting to be a part of this academic feast.
Yeah, it was a pleasure, Dr. Venkat.
Sir, I feel bad that you exceeded time. Actually, we could start late because of the technical difficulty. So
yeah, no problem.
We have to apologize for the delay.
No problem. It happens. Yeah.
Any queries from participants?
Okay, if there are no any queries, thank you, sir. Thank you once again. Yeah. Thank you for a very profound session.
Thank you so much.
Now we have come to the fag end of the session. We now request Dr. Uma Devi, Professor of Department of Pathology, Mahatma Gandhi Medical College and Research Institute, to deliver the vote of thanks. Madam.
Good afternoon, everybody. Can you hear me?
Yes,
I can hear you.
It's an honor to propose vote of thanks on behalf of Department of Pathology, Mahatma Gandhi Medical College and Research Institute. At the outset, I would like to thank our respected chairman, Shri Mr. M.K. Rajagopalan sir, and our beloved Shri Balaji Vidyapith University Vice Chancellor, Professor Dr. Subhash Chandra Parija, and our enthusiastic Dean of Faculties, Professor Dr. Ananthakrishnan sir, and our Director of E-Learning, Professor Dr. Ravi Shankar, and our Dean in charge of Mahatma Gandhi Medical College and Research Institute, Professor Sitesh Bose, and our dynamic medical superintendent of Mahatma Gandhi Medical College Hospital, Professor Dr. Nirmal Kumar, our GM admin, Asha ma'am, and our senior personal manager, Mr. Balamukundan. I would like to express our sincere thanks to all eminent speakers who spent their valuable time and effort to share their knowledge with us. We also extend our heartfelt thanks to all the faculties, paramedical staff, especially IT and Medical Informatics Department, and our Dean Office staff, Personal Department staff, and all the ones who work with us to make this virtual conference a great success. At last and not the least, I would like to thank all the participants, especially postgraduate students. Thank you for everybody. Thank you.
Thank you, madam. So with this, we come to a conclusion of this so-called academic feast. So with this, we come to a conclude. All the talks are over. Tomorrow we have the e-poster session. So if there are any participants in the e-poster session, an announcement for them. So you'll be made all the details about the e-posters by today evening, and a reminder will be sent in the tomorrow also, in the morning of tomorrow also. So kindly adhere to the time duration. Your time duration will be for 3 minutes, and after 3 minutes, 2 minutes is for Q&A session by the evaluators. So kindly log into the particular link at the particular time, and make sure you adhere to the slot number. Thank you.
Thank you all. Thank you, sir. Thank you very much.
To all the thank you to all the delegates for making this event a grand success. Thank you.
Thank you.